Bismillahirrahmanirrahim. Sorry for delay. Actually, there was some IT problem. So today I will discuss otitis media with effusion with you. This is also called blue ear and the secretory otitis media. Why I have selected this topic? This topic is very important because it can lead to hearing loss in children. Hearing loss causes severe problem and consequences in the form of delayed speech, in the form of poor learning of the children, and poor performance at school. So you can see balloons. Why I have posted this picture? Because inflation and blowing of the balloon opens the eustachian tube. And otitis media with effusion is the disease that is caused by obstruction of eustachian tube. Now recall the anatomy of eustachian tube. This is made up of fibrous tissues, cartilage, and bone, and it connects the middle ear to the nasopharynx. You can see this is middle ear, this is eustachian tube, and it connects the nasopharynx to the middle ear. So there are certain muscles, tensor villi palatini and the levator villi palatini. Contraction of these muscles opens the eustachian tube. And epithelial lining of the eustachian tube is ciliated columnar epithelium, and these cilia move towards the nasopharynx. So there are important functions of eustachian tube. One important function is it equalizes the middle ear air pressure to the atmospheric pressure by opening, by the contraction of these muscles. And then middle ear clearance. Middle ear contains serous and mucinous glands, and these secretions are cleared by ciliary action towards the nasopharynx. It also protects the ascending infection from nasopharynx to the middle ear. So you can see in this diagram, this is nasopharyngeal opening and this is the opening in the middle ear. And the certain muscles, tensor villi palatini and the levator villi palatini are attached to the eustachian tube. Most important function of the eustachian tube is equalization of atmospheric pressure and middle ear pressure. And opening of this tube, when we swallow, when we chew, and when we yawn, we open this eustachian tube, and middle ear eustachian tube equalizes the middle ear air pressure to the atmospheric pressure. So objective of this lecture is early diagnosis of the case with the help of clinical features and early treatment. So this scenario explains all the clinical features, clinical findings, and investigations required and the results of these investigations. So child will be of 3 to 5 years of age, and it is not an emergency. Patient will present in OPD. There will be associated clinical features of the diseases that cause the eustachian tube obstruction. Most common cause is adenoid. So there will be mouth breathing. There will be apneic attacks during sleep. Most important symptom will be hearing loss. That will not be acute. It is chronic hearing loss. When we examine the tympanic membrane, we will see dull tympanic membrane on otoscopic examination. When we advise the test, that is tympanometry, tympanometry is the test by which we can assess the functions of the eustachian tube. We can assess whatever present in the middle ear. Normally air is present in the middle ear, but if there is fluid, we will get type B graft. Then because of collection of this fluid, there is conductive hearing loss that can be assessed by investigation. We call it audiogram. Because most common cause is adenoids, so these adenoids can be seen through X-ray nasopharynx laterally. So it is non-suppurative inflammation of middle ear cleft. Again, non-suppurative collection that can be serous, that can be mucus. There are certain tests by which we can check the eustachian tube patency. Valsalva test, Toynbee test, tympanometry is the investigations. Through otoscopic examination, we visualize the tympanic membrane, and by the condition of tympanic membrane, we can see eustachian tube is blocked or eustachian tube is patent. Then important latest technique is endoscopic examination of nasopharynx. Through endoscope, we can see the opening of eustachian tube in the nasopharynx, and whatever the disease that is present in the nasopharynx, it can be some tumor, it can be adenoids, it can be simple inflammation due to allergy and infection. So these pictures explains these tests. This is Valsalva maneuver, blowing with closed nose and closed lips. So this is Valsalva maneuver. Toynbee, swallowing with closed nose and closed lips. Then endoscopic examination. We pass the endoscope through nose. So this is the picture of nasopharynx showing adenoids. That is the main culprit in this disease, and the opening of the eustachian tube. When these adenoids gets enlarged due to infection, they can obstruct the eustachian tube. So these adenoids can also be assessed by X-ray nasopharynx lateral view if there is big mass. So this mass must obstruct the eustachian tube. Tympanometry, that is the done by tympanogram. We get different types of graph. This is normal graph at the level of 0. So this is the normal peak and normal pressure. Whenever there is obstruction of the eustachian tube, we will get peak towards the negative side, so indicating negative pressure in the middle ear. When there is fluid in the middle ear, we will get flat curve like this. This is called type B graph. So again, this is secretory otitis media in children. We call it glue ear. Why glue ear? Because secretions are mucinous. Mucus glands are more in number in children, so secretion is very tenacious and thick secretion. In children, in adults, serous glands are more, so secretion is thin. It is called serous otitis media. So this disease is more prevalent in children. Maximum age is 3 to 5 years of age. Then after this, it start decreasing and 10% in 5 to 7 years of age. Then total disappears by the age of 10 to 12 years. This is because of adenoids, because adenoids maximum at the age of 3 to 5 years, then they start regressing and they disappear by the age of 10 to 12 years. But if we are not treating the patient, there will be complications of the disease at this age. So etiology, I have explained, is due to obstruction of the eustachian tube. There may be mechanical obstruction, there may be dysfunction of the eustachian tube. So mechanical obstruction is seen whenever there is mass obstruction. So in children, most common mass is adenoids. But certain growths of the nasopharynx like angiofibroma, that is benign tumor, and carcinoma, that is malignant tumor, then glioma, meningocele, and encephalocele. These are the congenital nasal masses and present at birth, and they can obstruct the eustachian tube. So dysfunction can be due to inflammation. Inflammation is usually seen in allergy and infection. So this infection can be due to tonsillitis, pharyngitis, rhinosinusitis. Sometimes there is rapid landing. This landing can cause barotrauma, can cause obstruction of the eustachian tube. Sometimes unresolved otitis, acute suppurative otitis media. There is infection in the middle ear and we give antibiotics, and this antibiotics removes the infection, but fluid remains inside the middle ear. So we will treat it as otitis media with effusion. Then malformation, certain congenital anomalies like palatal defects, there is malinsertion of the muscles. So there is dysfunction of eustachian tube. In Down syndrome, there is narrow nasopharynx. It obstructs the eustachian tube. So there will be problem in opening the eustachian tube. In certain disorders, eustachian tubes becomes patulous and flaccid, such as in rapid weight loss, muscle weakness, multiple sclerosis, and in pregnancy. So patient can present with otitis media with effusion. So why infections and this disease is common in children? Because of short, wider, and horizontal eustachian tube. In OME, most important is because function of the muscles are poor. So tone of the muscle is low. So this disease is really seen in children. Now pathophysiology, we will discuss each disease one by one. So main pathophysiology is dysfunction and obstruction of the eustachian tube. It will create negative pressure in the middle ear. This negative pressure will retract the tympanic membrane. There will be engorgement of the vessels. There will be increased intercellular distance and drainage of the fluid from the blood into the middle ear. And also, if there is inflammation, it will stimulate the seromucinous glands. So secretions of these glands will increase due to inflammation, and the collection of this secretion will cause problem in conduction of the sound waves. So there will be hearing loss in children. Palatal defects, I have told you, due to malinsertion of the muscles. So eustachian tube, there will be dysfunction, eustachian tube. Unresolved otitis media. We have treated the infection with antibiotic, but fluid remains inside the middle ear. So we have to treat this fluid, and we will treat it as acute otitis media with effusion. Allergy again will cause inflammation of eustachian tube opening in the nasopharynx, will cause obstruction of the eustachian tube opening. Then important thing is adenoids, that is seen in 80% of the children, obstructing the eustachian tube opening in the nasopharynx. So now we come to the clinical features. Clinical features, main clinical feature is hearing loss, that is chronic in nature. So patient will present with delayed speech, improper speech. Patient start pronouncing words differently. If we ask him to say school, he will say cool. If we ask him to say ice cream, he will miss ice, he will say cream. So there is improper learning. So there will be poor performance of child at school. So there will be change in behavior of the child. Child will sit closer to the telephone, will increase the volume of the television. And because of deafness, he will not listen to his parents and teachers. So parents and teachers will show more concern. Then there will be associated symptoms of the disease that is causing eustachian tube obstruction. If there is tonsillitis, there will be odynophagia, rhinosinusitis, there will be postnasal drip, there will be his clinical features of allergy like sneezing, itching, rhinorrhea. So this picture explains symptom of the child with otitis media with effusion. Child becomes dull, becomes shy because he is not listening properly. Now hit the goal like Pele, who lost his life last month. So proper diagnosis is very important. So diagnosis is made by clinical features, proper history, proper examination, then examination. Examination is done by otoscopy. The now latest is endoscopic examination of the tympanic membrane and the nasopharynx. So we will see certain features of tympanic membrane. We will discuss it later. I will show the pictures of these findings. Then tuning fork test, because patient present with deafness. So tuning fork test will show conductive hearing loss. There are two tuning fork tests, Raynaud's and Weber. Raynaud's will be negative and Weber will be lateralized towards the diseased ear. Tympanometry is the investigation, and this investigation will show negative pressure, will show fluid in the middle ear, and will show obstruction of the eustachian tube. Audiometry is the investigation by which we can assess the type of the hearing loss and the severity of the hearing loss. Then to find out the cause, we can advise CT scan, we can advise simple X-ray nasopharynx lateral view, we can advise, we can do allergy test to rule out any allergy. So when we examine the tympanic membrane through otoscope, we will see these findings. Tympanic membrane will be dull. There will be loss of cone of light, decreased mobility. When we examine the tympanic membrane and we ask the patient to do Valsalva or Toynbee, there will be no movement in the tympanic membrane. So we will decrease mobility of the tympanic membrane. Sometimes part of the tympanic membrane gets retracted. It is called retraction pocket. There will be prominence of the lateral process of the malleus. Handle of malleus will become more horizontal. Sometimes when air enters the middle ear, it is mixed with the fluid and there will be air bubbles or the air fluid level. Now this is otoscopic examination. This is normal tympanic membrane. This is cone of light. And this is lateral process of malleus. This is handle of malleus. So shiny tympanic membrane is the normal tympanic membrane. Now see what happens in otitis media with effusion. You can see thick tenacious secretions through tympanic membrane inside the middle ear. This is the tenacious secretions, blue ear. Part of the tympanic membrane gets retracted and the whole tympanic membrane gets retracted. So this is the retraction pocket. This is lateral process, prominent lateral process. This is handle of malleus. So in this, middle ear is full of tenacious secretions. You can see glue-like material through the tympanic membrane. Tympanic membrane is intact, but there is collection of fluid behind the tympanic membrane. Handle of malleus has become more horizontal, prominent lateral process of the malleus. In this picture, you can see air bubbles. So this is not normal. Air is mixing with the fluid causing air bubbles. These are the tuning fork test. Rennie's test will be negative and Weber will be lateralized towards the diseased ear. Audiometry is the investigation by which we can assess the severity of the hearing loss. So this is the level of normal hearing. Nerves are normal, but due to conductive presence of fluid, patient is hearing at this level. So this is the hearing loss. This ear bone gap indicate the hearing loss in children. So again, tympanometry, if there is negative pressure, peak will be towards the negative side. If there is fluid, we will get flat curve. You can see type B graph. Then find out the cause, because most common cause is adenoid. So we can advise X-ray nasopharynx lateral view to see the adenoids. You can see adenoids. They are causing narrowness of the air column and they can also obstruct the eustachian tube opening. This is the endoscopy of the nasopharynx. You can see adenoids in the nasopharynx. This is the nasopharyngeal opening of the eustachian tube. So endoscopy is very essential these days. Now, complete ENT examination is required to find out the cause. If there are tonsillar hypertrophy, tonsillitis, adenoid hypertrophy, there might be growth in the nasopharynx, there may be polyps, there may be turbinate hypertrophy, there may be rhinosinusitis showing postnasal drip, and the cleft palate, rule out cleft palate. Now we come to the treatment. Medical treatment is very important. We will give treatment to open the eustachian tube. So we will give topical and the systemic decongestants. Sometimes we give short-acting nasal decongestants like xylometazoline, oxymetazoline, and sometimes long-acting nasal decongestant that are steroid nasal spray that can be in the form of drops. If patient is having allergy, then we will treat the allergy by giving antihistamines. If patient has an infection in the nose and nasopharynx and tonsil, we will treat it with the help of antibiotics. Now, certain exercises are advised. Valsalva maneuver, Toynbee maneuver, and ballooning. We have discussed these maneuvers, and we give balloon to the child and we ask him to blow with the help of nostril. One nostril is pinched and he will blow balloon with other nostril. So this is very important exercise in opening the eustachian tube. Valsalva, blowing with closed lips and closed nose. Toynbee, swallowing with closed nose and closed lips. Now, if patient, there is no improvement, then because patient is, because hearing loss is creating problem in child behavior, in child learning process, so we will think of surgical treatment. We make an incision in the tympanic membrane that is called laryngotomy. Tenacious secretions are sucked out and we put a ventilation tube that is called grommet inside the tympanic membrane. So then treatment of the cause. If there are adenoids, adenoidectomy, tonsillectomy is advised. If there are turbinates, quadri of the removal of the turbinate, then treatment of the cleft palate is very important. So if there is growth in the nasopharynx, treat the growth. So adenoidectomy done through oral cavity, we remove the mass. So what happens if we are not treating the case? It will lead to complications. Presence of secretions in the middle ear, there will be recurrent otitis media. This secretion gets infected and there will be history of recurrent otitis media. Then there will be perforation of the tympanic membrane, leading to high degree hearing loss. And the inflammation of the middle ear will hamper the blood supply of the ossicles. So there will be necrosis of the ossicles, leading to severe degree hearing loss. That only be corrected with the help of surgery. Then tympanosclerosis. There will be adherence inside the middle ear. There will be calcium and the chalky deposition in the tympanic membrane and it becomes thick. Sometimes tympanic membrane becomes thin because of absorption of the fibrous layer. Whole tympanic membrane gets retracted or the part of the tympanic membrane gets retracted, so forming the retraction pocket. This retraction pocket can lead to formation of cholesteatoma. That is very dangerous disease. It can resorb the bone. It can cause paralysis of the facial nerve. It can go inside the cranial cavity. And it has been proved by certain studies that long-standing otitis media with effusion can cause sensorineural hearing loss because toxins gets absorbed in the inner ear and can damage the hair cells. Now this is picture of tympanosclerosis. You can see this is the adherence can be seen through the tympanic membrane and the white calcium chalky material deposition in the tympanic membrane. This is called retraction. Whole tympanic membrane gets retracted. There is the part of the tympanic membrane is retracted. It is called retraction pocket. This is the formation of the cholesteatoma. Pars flaccida gets retracted and can form cholesteatoma. So these are the references from this book. Any question related to this topic? Hello? Okay, so give your feedback. Thank you.